here at Cambia Grove. Yes, the meeting will be recorded. At Cambia Grove, we serve as a catalyst to transform healthcare towards a more person-focused and economically sustainable system. We do this in collaboration with the 5 points of healthcare: patients, payers, providers, policymakers, and purchasers, as well as with other aligned stakeholders and innovators. Our goal is to drive transformation by optimizing 3 key elements of the healthcare ecosystem: infrastructure, incentives, and culture. As part of this work, we zeroed in on data interoperability as a critical component of the infrastructure required to drive healthcare transformation. We developed the concept behind our fellowship program to enable innovators to take a deep dive into data interoperability, take on high priority projects, and then share their learnings with the community. This year's fellowship is in partnership with the HL7 Fire Accelerator Program, which includes the Argonaut Project, the Karen Alliance, CodeX, the Gravity Project, Da Vinci Project, as well as Vulcan. The Innovator Fellows are currently working to develop, vet, and standardize a framework for measuring the value of use case implementation, otherwise known as the value metrics framework, which you will hear more about today. These outstanding fellows are currently in the process of conducting interviews with subject matter experts from across the HL7 Accelerator community. As they have gone about conducting their interviews and having these really interesting conversations, they have identified many questions about interoperability itself, the importance of this work, and the significant barriers to adoption. So at this midpoint in their fellowship experience, we are thrilled to welcome our special guest, Miki Tripathi, the National Coordinator for Health IT, to answer these questions directly, as well as Alex Goss, our moderator, to drive the discussion. We chose to do things a little differently for this conversation, inspired by the more open and collaborative fishbowl format. Alex will direct the flow of conversation by calling on each of our fellows to pose their questions to Miki, while all of us in the audience observe from essentially outside the fishbowl. We have a little under an hour for this discussion, at which point Miki has to drop, and we will open the floor for you, the audience, to interact with Alex, the fellows, and in the virtual fishbowl, and essentially learn more about the fellowship experience, the value metrics work, and other questions of that variety. So please feel free to share your questions as they come so we can begin to identify themes and get ready to lob them in. As you can tell, to support this format, we are using the Zoom meeting environment, which is a little less formal and more interactive than your traditional webinar. There are a few different options for how you might decide to view the fishbowl. So if you'd like, please navigate to the top corner of your screen and select either gallery view if you'd like to see all speakers at once, or speaker view if you'd like to only see the person currently speaking. And throughout the meeting, please do keep your microphone muted to minimize any background noise. And as mentioned earlier, and as you, I'm sure, were notified, this event is being recorded and will be made available after we wrap up. So with that, it is now my pleasure to introduce the moderator for today's discussion, Alex Goss, Vice President and Senior Consultant at Imprado. Alex, over to you.
Thank you so very much, Julie. Okay, well, thank you everybody for joining us today and that introduction and setup, Julie. Very helpful to understand our approach, and we're going to take a bit of an informal style today and really helping us to explore the important topic of data interoperability and why it matters. I think this is a great opportunity for the Cambia Grove Innovator Fellows to be able to speak with one of our nation's leading experts and drivers towards interoperability. And I'd like to introduce Miki Tripathi, our featured guest today. Miki is the National Coordinator for Health IT at the U.S. Department of Health and Human Services, where he leads the formulation of the federal health IT strategy and coordinates federal health IT policies, standards, programs, and investments. Well, so thank you, Miki, for joining us today. This is a really neat opportunity for you to come together with this cohort of fellows who bring a breadth of perspectives and experiences. And they're doing some incredible work to advance understanding the value of the implementation guides related to the FHIR, or Fast Healthcare Interoperability Resource Standard, and its implementation guides. We're going to learn a little bit more about the fellows as I introduce them before they ask you a question. And we're going to run the gamut across the 6 fellows. But before I turn over the baton to the first fellow, I really wanted to help set a foundation of why we're here, why this is important, and ask you to give us your thoughts on why we are working so hard on data interoperability.
Sure. Well, first off, thanks, Alex, and thanks to all of you for your engagement, and look forward to the conversation. So let's see, why are we working so hard? Is that a question of why do we want interoperability so much, or why is it so hard to get interoperability?
Those are both great points. Which one would you prefer to answer?
Well, the why do we want interoperability so much is, hopefully, something that's, and at a top level is, obvious to everyone, right? That certainly for care, the ability to share information, across providers, across, the entire 360 degrees of, sort of the participants in an individual's care, I think is, sort of a win for the patients first and foremost, which is, what should be the ultimate goal here. As we know, in our system, it's not always obvious that's the ultimate goal of what interoperability is, or has the way it's unfolded. I think if we think more broadly just about what we've learned from the internet economy over the last 30-40 years, is that the availability of information is what fuels growth and innovation in almost every sector and every dimension that we see. I think if we learn nothing else, it's that information flow helps us grow in ways that are unpredictable. And that, to me, is one of the most important things about it, is that we can't architect it. We can't pretend that we know exactly how it's going to unfold. What we need to do is be able to open up the participation, open up the amount of information that more eyeballs in healthcare, more authorized eyeballs can get their eyes on and can get their hands on, and be able to do things that none of us, right now might even envision.
Yeah, I do think the aspect of plan, do, study, act as a theory is very germane, whether you're in a clinical or administrative, research, social determinants of health environment. The more the data we can analyze and understand and glean insights from, the better off we're going to be in making wise choices with our precious resources to really support that patient where they're at and in their current status of health and well-being. So thanks for setting that baseline for us. I'm going to go ahead and jump into our first set of questions. I'm going to ask Grace Turner to be our first participant fellow to ask you a question. Grace is a software developer with experience implementing FHIR standards, and is a graduate student at the University of Washington studying natural language processing in medical text. So Grace, would you please ask your question of Nikki?
Sure. So I'm really interested in the transition period between fee-for-service and value-based care, which obviously has downstream impacts on FHIR standards and how we move data around for those different kinds of contracts. And what I've noticed just offhand is that the administrative burden does increase as hospitals deal with multiple types of contracts. And I was wondering how you reconciled that with the government's stated goals to reduce administrative burden and reduce waste in the industry as a whole, and how you see the role of the government as well as ONC in general to ensure that that transition goes smoothly, easily, and quickly as possible.
Sure, thanks, Grace. One thing that, and I've been in the federal government now for 7 months. I had a prior, sort of tour as a federal employee back in the 1980s. I'm old. And working in the Pentagon, so it was a very different environment. So I wasn't as sort of sensitive to it. I was much younger. I wasn't as sensitive to what I'm about to say as I am now, which is that you have to know what your authorities are when you're in a federal agency. And so in particular, ONC has very specific authorities related to certification of electronic health record systems and technology enablement. I think of it as the supply side of health IT. some of the questions that you have, that you had just asked are really related in a way to the demand side, which is about, how do health insurance programs work? How do we pay for healthcare? And how do those, how do we have alignment of those different payment mechanisms and all of that, which we don't have direct authority over. I'm not trying to dodge the question, just wanted to clarify and point out, because I certainly have opinions on it, even though I don't have authority on it. I have lots of opinions on it. So to break that out a little bit further, I think it is a fair point, certainly, that we've seen proliferation of different types of value-based care designs, and just within the federal government we've seen that as well as, and then when you start adding what the private sector is doing, it can be pretty overwhelming. And prior to joining the federal government, I worked for Arcadia, which is a company that helped organizations manage all of these different contracts and manage the different data requirements that required to be able to do that. And it was a pretty Herculean lift for organizations that were living in a world of multiple value-based care types of contracts. So a couple of things. First is Liz Fowler, who was the head of CMMI, big driver of the designs in CMS, has already said that that one of the things that she wants to do is reduce the number and the variation of designs that are coming out of CMMI. So I think that's where that takes place. And I think that there's sort of already a lot of thought to saying that we've had a lot of experimentation. We've had a lot of experimentation with a lot of let 1,000 flowers bloom sort of approach, which frankly might have been appropriate for when CMMI was first launched, right? Because we didn't really know how all this is going to work, what the government role would be, whether the government could do this effectively. And now that I think we've learned a lot of lessons, there's a lot of effort now, I think, that's going to be paid to saying, how do we consolidate this, at least on the federal government side, to a few core models. So I think that'll be one piece of it. The other piece is that it's a little more challenging is I don't know that what levers the federal government has on private industry. The federal government doesn't directly regulate health plans in the same way. They have certain health plans that they do have some regulatory authority over, like Medicare Advantage, for example, where plans contract to do Medicare enablement, but by and large they don't have authority over the vast majority of sort of health plans that are out there in the country. So I think that would be sort of part of the challenge of how do you deal with that proliferation. I think from an ONC side, though, what we can do and what we're working on is saying, how do we have commonality in terms of at least the baseline information that these, wherever you are, provider, payer, whatever it is, that you're starting with the same foundation of information. And in our case, it's called the US CDI. I'm happy to dive into that a little bit more. But we're basically saying, the levers that we have for certification of EHRs and for standards are a baseline that cuts across the entire provider community in the US, at least not the entire, I shouldn't say, because there are lots of the care continuum that wasn't able to participate in meaningful use. But if you look at hospitals, and if you look at ambulatory providers, well over 90% of them use ONC certified EHRs, and the US core data for interoperability is kind of the minimum data set. And so, we're working really hard, for example, with CMS to say, whatever design you have, whatever you're doing, you should start with the US CDI and build from there, because that's what everyone has as their baseline already available in those systems. So we're doing a lot of work to say, what can we do from a technology perspective to get more alignment around standards? And then, of course, open APIs that allow the better sharing of information to reduce the burden of information sharing when those kinds of designs are needed.
Thank you, Mickey. That was a really useful answer. And I think it really highlights the critical role that ONC plays with the coordinator part of it, in that even if you don't have specific authorities like a CMS payer regulation might, you do a lot of coordination and orchestration to really help advance us. And I've even seen that as ONC's taken on helping with the intersection of clinical and administrative data. So I think it's a critical role to help us with the pivoting from fee-for-service to value-based care over time. So let's dive into our next question. I'm going to ask Chris Boyd to ask the next question. And let me give you a little bit of background on him. He is a data warehouse manager for the Washington State Healthcare Authority with more than a decade of experience leading health organizations in their maturation of their data infrastructure. Chris.
Thank you. Yeah, so as Alex said, I work for state government, and so we very closely watch the Fed for any changes or signals, because that trickles down to us. And so for me, the recent mandate by the ONC to build fire interfaces is really fascinating, given that the fire community is actually a volunteer community. So my question to you is, does this mandate signal the beginning of change for more explicit or more significant federal support, either in terms of policies or resources in the actual development of fire standards?
Sure, thanks, Chris. I don't think that the approach has really changed or any different with, with fire as opposed to any of the other types of standards that ONC has supported in the past, CCDA or any of the IHE stuff or, HL7V2, in that, everything that we have promoted and have worked very hard to promote are open industry standards. And all of those open industry standards go through the standards development organizations, which by and large are made up of, volunteer, really, an amazing amount of volunteer effort. So if there's any pinch point in the system, to your point, sometimes it is with those standards development organizations, which are based on volunteers. But that's been true for CCDAs, it was true for HL7V2, and it's true for fire because you're going through the same standards development organizations. I will say though that there is a little bit of a difference in that we have incredible uptake and embrace of fire, unlike any other healthcare standard, I think, at least in the recent past, and that's put a tremendous amount of demand on, like HL7, for example, the standards development organization, and by implication, all the volunteers who participate in those working groups. And the fire accelerators have, pardon the expression, have added fuel to that fire, right? Because you have the fire said, I'm as guilty as anyone, right? I found, helped to found the Argonaut Project. But, what we did is say, oh, we're going to accelerate all of this stuff and push more at you. and of course, you have Da Vinci and some others that, that have really doubled down on, trying to push more through, through that pinch point. So I think that's a big challenge for us, is how do we, sort of expand that fire community to, have more people who have that kind of technical and domain knowledge as well. Because I think one of the big challenges is, you can't have just informaticians. You have to have people who really have a good domain sense of how is this going to work in real life, and what are going to be the challenges with, with using these out in the wild. So I think that's one piece of it. And then the other piece is that, we're working really hard, and this is a part, Chris, where I will say that the fire community is a little bit different than others in the past, and that it is a community. I think there wasn't a sense before of, oh, there's an HL7V2 community, at least not one that I would have been a part of, but fire community, everyone wants to be a part of. But fire really is from the beginning, and it's actually fascinating if any of you go back and look at some of the Graham Grieve, who's sort of the George Washington, Betsy Ross of fire. If you go back and look at his early blogs, which are still available online, I think it's Health Intersections, I think is his thing. And you look at the early blogs from like 2011, 2012. He wasn't, a whole bunch of what he was talking about was, he was talking about, yes, we need to move to RESTful APIs and all of this, but then he also was talking about, the modern way that we do this is via communities. And you need to have communities around this. And importantly, you need to have the implementers involved from day one so that they're providing that feedback in. So in some ways it is different because, the creators of it were very much thinking that the whole way that this works, the whole way that we think about a standard, from its seed, going through an organic process and then going through a standards process is, sort of fundamentally different, in that regard, in the way that they thought about community. But I do think, just going back to this last point then, that that one of the challenges, the other challenge that we have is that, you've got this pinch point, which is constrained by the number of volunteers and, how much time they can give to it. The other is, how do we think about sort of, streamlining some of the standards development processes to be able to get them to, get stuff out the door a little bit faster. And I think that's, that's a real challenge, because on the one hand, you may want to, we're all tempted to say, you just need to do this stuff faster, just get it approved. But the other part of this is, wait a minute, these are ANSI certified standards development organizations for a reason. And they have to take very seriously that what they do is an industry standard that has to meet certain, expectations and requirements about what constitutes a real industry standard, a real open industry standard. So I think that's, sort of the balance that we have to strike. And we have to recognize that I think there are things that we can do to speed things up, but at the end of the day, there's always going to be that constraint of, if you want something to be an open industry standard, you have to allow open industry processes. And open industry processes are going to take a little bit more time than just any company deciding, here's my proprietary standard, ready, set, go.
Thank you, Mickey. I think it's really important to recognize that as a nation, we have embraced the concept of communities and village much more so in the last decade or so with the development of standards. I think we've learned from the HIPAA early days. And I think that I've seen the transformation over the last 20 plus years that we start with collaboration. It's not where we go when we don't have any more answers, as we've heard Chuck Jaffe say. And I think it's important that anybody who's listening to this webinar knows that they are welcome to come roll up their sleeves and join in to bring their expertise. And we need people from all portions of the healthcare continuum to really make these standards work, because it is an open consensus-based process. So if you are liking the idea of debating nuances, standards development is for you.
Right. I mean, I think, I haven't done this calculation, but if we did the math and asked ourselves, how much of our healthcare economy globally are we now relying on, I'll just pick one organization, but there are many standards out there, HL7 V2, CDA, and FHIR, all coming out of HL7. Right. And if we asked ourselves that question and said, how many organizations, how much healthcare is actually relying on these standards? And then you looked at the size of that organization and the resources of that organization, I think we would sort of say, whoa, wait a minute. There's a tremendous mismatch here in the reliance that an entire global ecosystem is relying on these standards and the resources that are available, to that organization. And that's true for, NCPDP, and it's true for IHE. I'm not, pointing just at HL7, but, HL7 happens to be, at the center of attention now with, with FHIR and the growth of that. So I think it's something that, we at ONC are, working hard on this thing. How do we bolster the standards organizations to be able to, take the rightful place that they need to be able to take in helping guide us to the future?
Thank you. We're going to go ahead to the next question, and I'm going to ask Rachel to ask this one. So Rachel Gerson is a practicing diagnostic radiologist and consultant to early stage companies offering expertise in product development and clinical implementation strategies. Rachel?
Hi, thanks for the opportunity. As I come from the clinical side, I come from the side that loves to hate the EHR, and where the refrain is often that the EHR was developed to capture billing. So my question is, in a fundamentally for-profit healthcare system, how can we envision data interoperability and re-envision data collection so that it creates value and improves outcomes for patients, that it supports the work of the clinicians who treat them, and that it provides useful data for research and development?
Yeah, thanks, Rachel. I think we need to focus on demand and supply. And to me, part of the problem, and this isn't necessarily a popular opinion, part of the problem is that when we say, how do we get more and better interoperability? To me, a part of that is to say that people need to demand more and better interoperability. And I think that part of the problem here is that healthcare institutions, individuals within healthcare institutions, don't demand interoperability like they demand other things. They demand to get paid. I mean, so, we can sort of criticize, EHRs are focused on that. At the end of the day, an organization will say, if the revenue cycle isn't working, I'm not doing this. But if interoperability isn't working, we'll carry on. And I think that's just the reality of the way sort of the system works. And so I think that it's about having more and more demand and higher expectations on what we want out of interoperability. I think that's already happening. I mean, I think now that these things are in place, I spent a lot of time implementing EHRs, and always saw the cycle in individual providers and organizations' minds of this not being an either or, but it's like, I need the revenue cycle to work first, because if we're not getting paid, we can't do anything. But once the revenue cycle is settled down, and I understand that, now I can start to think about, the other things I want to be able to do. I can think about how do I get better adoption of the EHR, and then finally, how do I think about interoperability? And I think if you look at it as sort of a, an entire ecosystem, I think that you can see that everyone is, sort of pushing in that direction as a higher expectation and, a higher standard of care expectation that you would have that kind of interoperability. But going back to Grace's question for a second, which I think ties to this, to me, the biggest driver of interoperability is value-based care. I mean, I've, just in my experience, again, working with organizations, I've seen so many organizations like almost overnight flip their perspective. We're working with them on EHR adoption, implementing this stuff and that stuff. And it was always an uphill climb to get them to think about interoperability and aggregation of data for analytics and being able to, look across their entire, sort of portfolio of practices and everything. And then they sign a CMS MSSP contract. And the next day it's, where is my interoperability? I need to know what's happening to my patients. I need those ADTs and I need it today. Where is it? They're not. So to me, that's really the driver. It's got to be something that's baked into the business of the, of the healthcare institutions and is made available to the providers, who many of whom have the instinct of wanting to be able to, have it. But again, it's got to work for them. It'll work for them from a clinical perspective, but unless it works for them from a business perspective as well, at the end of the day, we're just not going to get that interoperability.
Thank you. I think it's always challenging as a patient to know how hard to push and what you should expect. And I think we're evolving our culture around that. Some of us who are deep into this work actually do read the HIPAA privacy statements. They just kind of want to wave by you. But I think it's also hard to understand for all of us, even those who work in healthcare interoperability and the healthcare continuum, just all the enterprise components that have to work together. And so it is very complex, not just the data we deal with, but how all of it fits together. So hopefully we're going to be able to continue to make some progress on that front. Let's dive into our next question, which I'm going to ask Sherry Cutler to ask. Sherry is the Assistant Director of Clinical Informatics at Pullman Regional Hospital. She has over 20 years experience in clinical informatics, risk management, and quality measures. Sherry?
Thank you for the opportunity. So I too am a clinician, and my focus really is kind of out in rural America. So I work at a critical access hospital here in Pullman on the eastern state of Washington. There's 39 critical access hospitals, I think, in Washington. So when we talk about data analytics and big health systems, I feel like the question that I have really is focused for that kind of focus with rural small hospitals limited by funding and resources. What thoughts do you have on what can or what might be underway to help underserved areas that need to remain competitive with skills and systems, so that robust health IT is not another social determinant of health?
Right. Thanks, Sherry. And I like that phrasing, so that it's not another social determinant of health. I think that's a great point. So a couple thoughts there. One is, I think that, with the meaningful use program and, and high tech related stuff, the good thing is that, it did establish a floor that cut across, at least for hospitals and, ambulatory providers that were able to benefit from those incentives. At least it provided that floor, which I think is, a good thing. But to your point, there still are differences and disparities in the resources available, for the health IT that's available for, for the better resourced and the less well resourced. So there is certainly that divide that we need to, now take into account. So, we're doing some work in ONC to try to say, how do we characterize that divide, both for those who have adopted EHRs and have certified EHRs, but maybe those are even at different levels or different capabilities, and then also looking at the other parts of the care continuum that didn't benefit from any of that, and saying, all right, now what can we do about those parts of the care continuum as well? Because those are incredibly important and equally important in some regards. And certainly if you look at federal dollar spend, like Medicaid in particular, a lot of that goes outside of the hospitals and the ambulatory providers and into LTPAC providers and behavioral health and mental health and all sorts of other places where where they didn't have the benefit of those. So we're looking really hard at saying, are there ways that that with the Congress we can get more resources to be able to get incentives for for lifting those up, but in parallel being able to say, that what are all the levers that we can pull internally, looking across HHS. And we're just at the beginning of that process. We just had a conversation with CMS about this yesterday, to sort of say we need to start thinking about that in a little bit more of a systematic way. First is getting an understanding of what is that digital divide to the extent that it exists, because it's different in nature. If you think about, and you pointed out, we've got critical access hospitals, rural hospitals that have an EHR. It's a certified EHR, but it's different than what Mayo Clinic has. So that's a different, digital divide than the digital divide that exists between, Mayo Clinic or that hospital and a mental health center that has, just very, sort of rudimentary access database maybe, or like a front end system, but they have nothing for their clinical records. So first, it's about characterizing that and characterizing it across the landscape, and then thinking about what kind of levers we have in place. I think the other thing that I should mention, though, and coming back to to FHIR, is that the ability to have more lightweight based apps that allow certain types of functionality, but don't require a full-blown certified EHR to get certain things accomplished, like connectivity with other with other systems, like the ability to have FHIR-based apps that can allow other types of functionality to be able to be a part of my system, even though it's not a part of my core platform, delivered at much lower cost and with much less organization investment in terms of time and resources. I think that's another way that you can imagine being able to close that gap through use of more modern types of technologies that are sort of more of a platform type approach.
I really like that idea, Mickey, of fast healthcare interoperability resources is also about getting speed to market, which if it's lighter, easier weight to build the data components together and deploy that software, that we should start to see a return on that investment in being able to get it farther and wider out in the community so that more people can leverage the modern technologies. And when we think about some of the challenges that we have in the rural communities related to broadband access, the lighter weight, more slick, the software that we can get out there to folks can actually help with overcoming that divide.
Yep, absolutely.
Yeah, so thank you for that question, Sherry. All right, I'm going to move on to the next question because I'm hoping that we're going to be able to also get to some audience questions here today.
Right.
And we're doing really well on time, so thank you, everybody. So Sarah Green is going to be our next fellow that asks a question. She's an accomplished health services researcher with expertise in creating research networks, patient-centered care, survey methods, and real-world data, as well as learning health systems. Sarah.
Yeah, thanks, Alex. And Mickey, I've watched and admired your work from afar. It's great to have a chance to hang out with you today.
Oh,
and
thanks, Sarah.
yeah. And I've had a wide range of experiences with and different exposures to healthcare stakeholders. And you've likely seen the degree of competitiveness that's legion among these different stakeholders, whether they're competing for market share or leveraging ratings and reviews or distance from the parking lot to the front door, or whatever it might be, So I'd really love to hear your thoughts on how we might harness this inherently competitive nature in healthcare to make forward progress toward interoperable data. Could we really start to use interoperability as a differentiator in a virtuous way?
Yeah, thanks, Sarah. It's a great question. So, I don't know if so we've been thinking about this since the beginning of HIEs, at least, in my time, 20 years, thinking about HIEs and always thinking today, that how do you find that, that piece, which is not about competitive differentiation, that's good for everyone, and then it allows people to compete on the right things rather than the wrong things. And so, when I was out in Indianapolis, getting my start in health IT, like in early 2000, and writing a business plan for what eventually became IHI, the Indiana Health Information Exchange, it was a huge lift, but ultimately successful. Where we went around to all the hospitals in Indianapolis, and so IHIE started with John Kansky is now the head of it. He's taken it many more dimensions than where we started. But when we started, it was basically saying we need to have a common platform for lab results delivery. I mean, that was all that it was about. It was saying we can do this more efficiently. And literally the cell where I spent 2 years commuting to Indianapolis from Boston was walking around to all the hospitals and then circling around again and circling around again and circling around again, convincing them that lab results delivery is not a competitive differentiator for you. It is absolutely not. You should think of it like your laundry service. They have a collaboration in Indianapolis where all the hospitals participate in a centralized laundry service, right? Just for scrubs and all that stuff. It's like, that's just commodity. And that took a long time for us to convince them that lab results delivery is the same thing. It's just like that. Once you compete on what you're able to do with that information, let's not compete on your ability to get a physician to come into your little portal or or doing it your way because you think that's going to create stickiness where it's not. They just actually hate you for it. And so but to your point, it takes a lot of effort to convince people that things that they think are competitive differentiators actually aren't. And how do you sort of have that conversation about saying how do you commoditize this? In some ways, we're kind of scaling that up. If you scale that thought up to what we're trying to do at the industry level, I would say that in some ways it's very similar, which is to say that what I would like to be able to see is how do we have a platform-based approach to to this entire ecosystem, and we've certainly seen platform technical models and platform business models and every other part of the internet economy. You think of two-sided models, multi-sided models, all of that have just had a huge impact on the way that people share information, on the business kinds of opportunities that you start to see, on the value that you start to see being delivered in those kinds of mechanisms, and things getting quickly commoditized when they're just easy to to share once you've got that kind of platform approach. And so as we think about EHR systems, for example, and FHIR and APIs, our whole push has been to say these EHR systems need to enable open APIs so that they can be those kinds of platforms. So that, going back, I think, to a little bit of Rachel's question, related to usability, these really billing systems, to me, a part of the answer to that is to say, if I've got a platform EHR, I can start to bring in apps that help to deal with the issues of, I don't like the way that my EHR does this particular function, or it doesn't do something that I really want it to do, and my EHR vendor has told me it's going to, it's on their roadmap, but it's going to take 3 years for them to get it done. Why can't I just plug in an app that's coming in from the outside and be able to have that functionality? And then the EHR vendors are, we're basically saying, how do you commoditize that basic documentation API exposure kind of function? And then you're still, each of the HR vendors differentiates on the stuff that is baked into their EHR system and the functionality that they provide. But you're able to start to say a whole bunch of that really should be commoditized so that you can have a world of platforms where you have that kind of differentiation. And perhaps in a great world in the future, the differentiator will be, how open are you to apps, right? How are you the platform that the docs really want? Because it better supports apps integrated in a more facile way than the other system.
Thanks so much.
Yes, I really like hearing your perspectives there, Mickey, because we're really talking about how high tech and 21st century cures related policy have really driven us towards a whole new way of competing and a whole new layer of economic aspects for organizations to think about as they do their daily care delivery and all the functions that wrap around it. And it's we have, over the last 30 to 40 years, federal policy and industry collaboration has really created an iterative way of looking at how we compete, and especially as we focus our competition in our markets around really good patient care. It's interesting sort of dynamic.
Right. And it takes ongoing cultivation, right? It isn't as if it's over. I mean, just think about what's going on with with Apple and Epic, the other Epic, the creator of Fortnite, right? And all those battles that are going on with the Apple App Store and the changes that Apple is having to make to its App Store. It's that's exactly the same dynamic that we're talking about here, just within the EHR space. And as we think about, so the EHR vendors having their App Store, if you look at our regulations related to business practices and pricing models for APIs, it is just a microcosm of that larger Google Play, Apple App Store phenomenon of how do you have a set of ground rules that enable a level playing field for the app developers of the world to be able to compete competitively in an environment where you have EHR systems in place. So it's a lot of it is sort of that same phenomenon, I think, and and trying to break through a lot of those kinds of things to be able to have as much of a competitive and open and innovative marketplace as we can.
Thank you. So we have one more fellow in the queue, and I just want to do a heads up to the audience attendees that have put questions in. I'm going to hopefully pivot to a few of those questions. So I'm going to likely ask you to come off mute and ask your question directly to Mickey. So just a heads up to the handful of people who've been giving us some great questions in the chat box. So Steve Lamb is our next fellow that I'd like to introduce. He's a clinical pharmacist client manager for Regions, where he supports both clinical pharmacy services and account teams in meeting the needs of various clients and lines of businesses. Steve.
Yeah, thanks, Alex, and it's nice to meet you, Mickey. So with us being fellows, we've had a chance to interact with a lot of different stakeholders within the FHIR and interoperability community, and we know that there's a large presence locally within the United States, but FHIR as a standard is international. So, with the Global Health Digital Partnership, it's really provided a forum for governments to exchange best practices, data sharing, and interoperability standards around digital health. So my question for you is, are there key themes and challenges that have really emerged at the global level during the pandemic that has accelerated adoption? And the second part to my question is, how has the US been engaging with these GHDP partners over the last several years?
Sure, thanks, Steve. So yeah, in the GDHP, we're very involved in. So we were there at the founding in 2018, which is not that long ago, and we're currently the vice chair. So Steve Posnack, who's the deputy national coordinator, is the vice chair of GDHP, starting just now, I think. And so we're not only very involved, but playing a leadership role with the GDHP. And also there are 5 work streams with the GDHP, and let me see if I can remember them. There's a policy one, there's a consumer engagement one, there's a security one, there's an interoperability one, and there's a evidence and evaluation one. And we chair or co-chair, I think we chair, but maybe it's chair or co-chair 3 of them, or 2 of them, interoperability and the cybersecurity work stream. So we're very involved, both the leadership level and then at the ground level, and we're very involved in the founding of it as well. So I think there's a lot of work that we're doing there now to sort of say, how do you have the alignment around sort of the global community and with other nations about sort of alignment on certain core things. So one of the things that we're working on is sort of a standards sort of document, a global standards document that can help to document and align the use of standards across different countries as a reference point, and hopefully as a way of getting convergence and consensus where there may be misalignment. And I think that to your point of what has happened during the pandemic, I think that there are more and more conversations happening related to things like vaccination credentials, for example, and how you can have alignment for those countries that have national level digital vaccination credentials, which the U.S. doesn't have, but you see certainly within that community a lot of discussion around the EU versus the UK versus WHO standards, smart health card standards, blockchain, a whole bunch of that conversation that's saying, how do we have alignment across of those, and how do you make those interoperable, and what does it mean to make those interoperable as well? So I think that's a really important forum for us to be able to continue those conversations and to keep going. I think the other element of you had mentioned FHIR as well. FHIR is a global standard. To your point, it's it's interesting that if you look at just even in the time that I've been in health IT, which is 20 years, we were sort of in the U.S. a little bit behind the rest of the world. In health IT, and then high tech came along, EHR adoption, and all of a sudden, the U.S., because of that high adoption, a lot of resources paid to it, and of course the rapid adoption of FHIR in many ways faster than the rest of the world. Now we're, the U.S. realm is driving a lot of what happens globally. I think and I was on the board of HL7. I think that before joining ONC, I think there is a lot of work there too to start to think about how do we have this. We don't want this to be just a U.S. thing. Right, it's just that the U.S. had resources, the U.S. had regulatory authority to start moving forward on this stuff. But how do you sort of say we need to be pushing this out into the into the global markets so that you can have that kind of adoption in other parts of the world that we're seeing today.
Thank you. Very, very helpful. Also shows your degree of participation or degree of coordination at so many different levels. And when you take on the global effort, it's really kind of mind blowing to think about all of the wrangling, coordinating, and consensus building that.
You're telling me. I mean, I joined ONC and I've worked very closely with ONC, but from the outside, and then And then 7 months ago, just crossed that little border wall. They opened the door, they let me in, they closed the door again. And now I'm on the inside. It's like, wow, we have a whole global health program here. I had no idea. And there's a tremendous amount of work there, to your point. And then we also do a ton of work with across federal agencies. So again, from the outside, I never really appreciated how much work there is with the coordinator part being across the federal agencies as well.
Thank you. I'm going to take a little bit of liberty on where we start in our next set of questions. I know the fellows have prepared a lot of questions for you, and in consideration of our audience and the tie of fire and the value in the marketplace and why what the fellows are focusing on, I'm going to ask two gentlemen to come off mute. I'm going to ask Kirk Anderson and Dave DeGandhi if they would join us for this next portion. I think that Dave DeGandhi's question that he put in the chat box is a very germane one, and I'd like to have him ask you that specifically, but I also would like to have Kirk Anderson, who is very much of an innovator and driver of nationally of healthcare transformation, to also join in this portion of the discussion. So without further ado, Dave DeGandhi, please.
Right, thank you. So my question, I'd like to hear you say the comments about making the data exchange a commodity. That's the goal of interoperability. And this fellowship program has been interviewing use case subject matter experts from all the HL7 fire accelerator projects, trying to capture points of value that stakeholders may experience as a result of an organization implementing a specific use case. We're going to compile this information into a value metric framework and make it available to the public as reference point for those looking for ammo to make their case in their organization to do implementations. Can you envision how this value metrics framework product might be used to accelerate the timeline to accomplish the healthcare data exchange goals, commoditizing the data?
Yeah, that's great, Dave. Thank you. So that sounds like great work, and I'm happy to talk about how that might be really valuable. And to me, the fire accelerators, the ones that are really effective are and I think all of them are really effective, but because they're focusing on use cases and not just about the creation of standards for the sake of standards. So I think that value metrics framework, if I'm understanding just based on your description of what that's going to be, is are they fulfilling the promise of saying, all right, we start with real use cases, and at the end of that thing, that should deliver what I like to think of as concrete goodness to someone, so that they can actually pick it up and do something that solves a problem that they have in life. Right, because that's the whole point of any of this technology, right? It's like, and the ones that the people always innovate around. I have this problem that is driving me bananas. Let me figure out a technology solution to it, and then get that in place, and then and then help me move. So if the value metrics framework sort of is able to sort of document, here is the particular use cases, and here's the value that one might see coming out of those, then you're able to sort of step back and say, how does that rank against the priorities that we have as an industry? How does that rank against the other fire accelerators and what they're doing, and where do we see complements, where do we see overlaps, redundancies, and then how do we do that sort of framing and prioritization going forward, because I think one of the other challenges is as we have more fire accelerators, I mean, on the one hand, you want to have a focus on things that people are really going to do, but you always have the challenge that some of these things go through the HL7 process and then they sit on the shelf. Right. So at the end of the day, you've got a whole bunch of implementation guides sitting on the virtual shelf, and you say, well, job well done. It's like, great. And now no one's using that for anything. So I think that, if that value metrics, sort of approach can also take that into account, like what have we really seen with those artifacts, to the extent that some are mature enough, I think that'd be a really valuable contribution that I don't think anyone is really looking at and stepping back and saying, hey, do we have a report card on the fire accelerators and the artifacts they've created? And I can tell you from an Argonaut perspective, we had a very mixed, but we had some real great successes for sure, and some industry driving successors, but there were a bunch of other artifacts that we created that basically sat on the virtual shelf. And a little bit of that, and maybe I don't know if there's some way of capturing this in the value metrics framework, but all of those, at least from an Argonaut perspective, I can speak to that because I was very involved in that, is we started with a set of criteria where we said, we're not going to do projects that aren't of industry importance. Like, just not interested in doing that. And we had a set of 3 or 4 criteria. One was, also, can we get it done within a year? Because if it's going to take us 5 years, forget it. Again, it's it's not mature enough, not ready for fire enablement. And do we have a really good line of sight to enough players who are saying, I'm actually going to implement this. I will, because my customer's demanding it, whatever. So we use that criteria, then we enter this process, then we create these artifacts, and then we still find like 50% of them are like, oh, okay, well, no one really picked them up and ran with it. And then you go and talk to the vendors and they're like, well, I thought that my customers wanted it, but then when we had it, no one actually wanted to do it. Like fire scheduling, for example. We did a full, a thing on fire scheduling. Fire questionnaires was another implementation guide that may see life now as CDC and others get into this. But I think that would be an interesting thing to look at as well. I think that almost all the fire accelerators start from a perspective of thinking, these are really valuable in the market. I know because I'm an implementer. And then 12 months later, it's like either the market changed, or I didn't guess right, or there was some other reason that it didn't get the traction that we expected.
Thank you. Middle of October, we'll have a work product, and we'll try to get that in front of your face.
Oh, that'd be great.
Thank you.
So Kirk Anderson.
Hey, Kirk.
Hey, Mickey. How you doing?
Good to see you again.
Yeah, good seeing you again. I just wanted to come off mute quickly here and thank you again for speaking to our fellows today, and also for your leadership nationally over the years. You called Graham Grieve the George Washington of interop. I'm not sure which founding father that would make you, but you're definitely on the Mount Rushmore somewhere. So
thank you. I appreciate that.
Absolutely, and so we were delighted at Cambia when you assumed this new role at ONC, and look forward to your continued leadership. I am going to sneak in a quick question, and then I want to make sure our fellows and the rest of our attendees get their turn as well. But you spoke earlier about the momentum in the app community to help support our goals nationally in interop. And at Cambia, we've been active in that community as well, and have built some smart on fire apps supporting value-based care initiatives through DaVinci. In my opinion, the great leap forward that we need is going to come when the EMR vendors themselves, like Epic and the others, start to bake in native support for some of these use cases so that it's in their core product offering and not something that has to be added on as an app. And I know Epic and others are thinking in the same way, and we're excited by some of what they've demoed for us. But I'm just wondering if you have a sense for, is that a future that's coming, over the next 1 to 3 years? Do you think this will just increasingly become table stakes when you buy an EMR product?
Yeah, I mean, I think it is. I think it is coming very rapidly, and and I think we're going to see. I mean, to your point, fire is just a technical standard, right? And there are different models for implementation. There are different models of thinking of what's the boundaries of my software and my product versus the boundaries of what I'm going to enable. Sort of living outside that boundary. And every vendor is actually going to make different decisions along those lines as well. So, to your point, I think we're going to see many vendors that are going to start to bake this stuff in more natively. I mean, right now, as we know, because none of these systems were designed with a fire model in mind, all of them are fire overlays, right? I mean, that's, all of them are. It's unclear that fire is necessarily the best way to store data or to, maintain data for the kinds of things they do for transactions and, all the other things they do. But, leaving that aside, I think to your point, we will, start to see sort of more native development, in the fire realm. I think that, one of the things for us to just as a point of perspective is that, everything we've seen with fire, and it's a lot. I think we'd all agree, right, that it's a lot. It's not only sort of deep, meaning you've got EHR vendors doing more and more, and you're talking about a greater depth of saying this isn't just a fire API, facade on whatever it is I've got underneath it. This is about saying, no, I'm going to make it, sort of native to fire capability. So it's going deeper and deeper, but it's also the breadth that that it's not just providers, it's payers, it's life sciences companies, it's, every federal agency now has some kind of fire roadmap or fire plan. So I think that's like just tremendous progress. And all of it, literally all of it, without an ONC requirement that anyone implement FHIR to date. Right now, CMS actually jumped out ahead of us. Well, we got delayed, so the CMS interoperability rule does require FHIR, implementation according to the implementation guide that, we have in our rule for a patient-facing API that started in July of this year. But literally everything that has happened right now, the FHIR requirement, as many of you may know, now doesn't kick in until December 31st, 2022. So everything that we have seen is based on the momentum and the possibility and the opportunity of FHIR, not based on ONCs telling them they have to implement FHIR. So to me, that's going to be like a real turning point, I think, because what that does is right now we see a lot of variation still in what's enabled with with FHIR. You got some people are still on on STU2, and then I think most people skipped over R3, but then R4, and still a lot of that variation across the market, which makes scalability hard. But once that ONC requirement kicks in at the end of December, then you'll start to see that everyone has to implement that particular implementation guide for sure. It's a technical requirement, not a functional requirement. And then you'll start to see, I think, the opportunity to for people to be able to settle in and say, okay, I have to implement that implementation guide. Now I can think about how I make it deeper in my product, but also how do apps now find better scalability than they're finding today, because that variation is still a real barrier, I think, to the kind of thriving app economy that we want to be able to have.
Great, thanks.
Welcome you. I mean, does that make sense to you? You're in this.
It does. No, absolutely.
Yeah.
Agreed. And I think, you mentioned earlier the demand signal, and I think the demand hopefully is going to start coming from the EMR customers, the providers themselves, to say, look, we want an integrated experience for value-based care, which is increasingly important to them. We don't want to have to deal with many different bolt-on apps. And so, make it as a seamless experience for our clinicians as possible. And if that's something that the EMR vendors are now competing on, awesome. Then we all win. And we don't have to rely on regulation to get us there. It's just part of how those products are successful in the market.
Right. Yeah, it just speaks to, the more we demand, the more we want, right? Because like right now, I'm just saying, if I could just have platforms that support apps, that'll be great. And you're jumping to the next level and saying, next level. Then I got all these apps.
Yeah,
That's
I really
progress.
hope that we don't keep ignoring our lessons of the past about integrating workflows, seamlessness, reducing burden, avoiding friction. I think that as a village, I've seen a lot of embracing of those past experiences and the scars that we've all developed from those. And so I want to recognize that Mickey, you are a popular man in demand these days, and we committed to having you done in an hour. So I'm going to ask you for your parting words to help keep you on time so you can make your next commitment.
Oh, great. Well, thank you. Yeah, and I apologize. I have to jump off. I have a call with OMB, and that's another lesson for in the federal government. When OMB calls, you basically say, yeah, no, I will be there. Don't know what's on my calendar, but I will be there. But no, first off, I just want to thank all of you, not only for for inviting me to be here, but for all the tremendous work you do. I mean, I think it's really this innovation community, which is what this is all about. And you're, just reflecting your questions is, you're banging on the door of saying, I want more, I should expect more, and we need more from the entire ecosystem. We should be demanding more of this stuff. And then I'm confident that we'll be able to have supply respond. So I think that's really important thing for, for all of us and for all of you to be working on. And I think it's, tremendous with the fellows, the kind of experience you have. I was able to scan the bios and, that you're very well placed to be able to think about both the technology and the workflow parts of it. Because I think it's one of the challenges for us as well. We've got a lot of startups, and I know a lot of you probably work with them, who don't have the domain experience. So they think, 30% waste in healthcare, easy, I'm going to create my app. It's like, you really need to understand how healthcare works to be able to know what's really going to work. How is this stuff paid for? How do the economics work? How do clinical workflows work? So anyway, this is a just really fantastic group here, and I really enjoyed being here. So thank you very much. And please reach out. If you can send the questions at the end of this, I would love to see what the other questions were that we weren't able to get to. You can just email those to me, and look forward to the opportunity to communicate again. And please feel free to reach out, mickey.tripathi@hhs.gov. We try to respond to anyone who has questions, concerns, advice, all of it. So thank you again.
Thank you so much, Mickey.
Okay, great. Thanks. Bye.
Wow, that was a lot of great information. I'm trying to savor all of it in the moment while I'm trying to think on the fly where we're going to head next. And I think that there's some opportunity here for us to talk a little bit more about what the Fire Accelerator process related to value metrics is about. I also think there's some opportunity for the fellows to have a bit of a round robin about what they heard and how they think that feedback shaped some of their work as they move forward over the next, I guess it's only 6 weeks, 8 weeks left of the program. And so I'm gonna invite Julie to give me a little bit of thoughts and guidance if she'd like, otherwise I'll just keep going.
No, absolutely. I think that's a great idea, Alex. So we have about 30 minutes left, a little less than 30 minutes left here together, and obviously lots that we can unpack. So I'm thinking, Alex, I love the idea of reflecting and having the fellows reflect, and then also saving some time for the audience to ask questions of you and or the fellows about the value metrics work, the fellowship experience in general, et cetera. But first, I actually think, Alex, although I'm sure it came out, loud and clear throughout the conversation today, I'd love it if you could maybe say a little bit more about your background. And then from there, maybe share a little bit of an overview about the value metrics work that's underway.
Thank you. I have been working in the healthcare field for well over 30 years. It's really hard to believe. And I cut my teeth in operations management, really thinking about how to get the data and the processes to work in a Medicare environment at a Big Blue. And that led me into doing internal staff consulting related to systems integration, policy, and workflow modernization to really try to harness delivering Medicare claims processing at the best price point possible and to support our seniors that are receiving health benefits under the Medicare program. That led me actually to representing CMS at X12. This was as we were entering the era of what's called HIPAA, administrative simplification, from which then I went and spent some time as a vendor after doing some consulting work and being an actual technology vendor for a while, in parallel to my experience in leadership within the X12 standards development organization that does the medical side of the HIPAA transaction standards, I decided to take a jump into health information exchange and join the governor's office of the Commonwealth of Pennsylvania to spearhead some health information exchange initiatives, ultimately standing up an agency to govern that in Pennsylvania. And decided to make sure I was taking care of my own health as a result of some Lyme's disease. So I took a little sabbatical and decided what I was going to do next, which was to really lean into helping organizations through strong governance, good communications, good strategic plans, really help figure out how we were going to continue to improve the healthcare system, which has included a role within the HL7 Da Vinci project for the last couple of years, and really draws upon my background, not only in the business world, but also as a federal advisor to HHS. I sat on the National Committee for Vital and Health Statistics for 8 years. And also in my HIE role was the state HIT coordinator. At the same time, Mickey was doing a lot of that work for Massachusetts. So I bring to you a very diverse background, but at the core of it, I'm a practical girl who wants to get stuff done. And I want to do it well, and I want to do it linked arms with the people that around me that are smarter, brighter, and have different perspectives, because this really takes a village to enable us to take care of our fellow humans. And my career is really based upon my passion that came out of my teenage experience of working at a hospital and a lot of family members that have had extensive health issues over the years. So I'm very passionate about this topic. And I think that part of the reason that standards are so important is that there's the foundation. It's the glue that holds us all together. The data, the people, and the ability to share that information gets us to all those insights that we heard that we want to garner, that Mickey was referencing. And when we look at healthcare, it's clinical, it's administrative, financial data, but it's also public health, research, social determinants, and community-based aspects. and that affect us in a lot of ways. And so part of our journey with fire is to also be able to learn from the past, as I noted earlier, but it's also to figure out how do we help organizations that are really busy with limited resources pay attention and understand the value for the various pieces that need to come together. And so the Cambia community, so the Da Vinci community with the Cambia leadership really recognized that we were missing this value metrics portion of the conversation and said, hey, Da Vinci, would you be willing to spend a couple hours looking at this topic? And so Dave DeGandhi, who you heard ask a question earlier, was the focal point for the conversations, and I provided a bit of staff support to him in trying to figure out what would a framework look like for establishing value about an implementation guide that uses the fire standard. And then how could that model of thinking of what is value to the different stakeholders, what does that look like, not only for the value-based care arena for Da Vinci, but how does that really touch upon the other fire accelerator communities? And so from that conversation, then Cambia Grove picked up this idea of how do we leverage the value metrics conversation with this year's fellows program? And so that kind of brings us all the way full circle back to here, in that the fellows have the not easy task of interviewing the fire accelerators and taking the model that the Da Vinci community developed as a preliminary framework, but trying to really prove that out in helping us articulate why an implementation guide is worthy of being used, of being adopted, and how do we get business leaders that need to fund and support business analysts, developers, architects, and other people, software developers, in really embracing standards and making them come to life in a way that is actually highly transparent, but we never think about it. It just happens. But that's part of fueling the life cycle around standards development all the way to software deployment. So thinking about the role that we've established for the fellows in this year's program, and thinking about that conversation that we just had with Mickey Tripathi over the last hour, I'm curious if to hear from the fellows about what are you thinking about? What's next? How did that conversation shape your view of what is value and where we're headed in trying to help everyone articulate that in a better way?
I think that sounds great. And so let's bring all of the fellows to the stage if we can spotlight everyone individually. So you're all front and center. I think that's a great place to start. And I will also just quickly plug that we are going to launch a poll here momentarily that will pop up on your screen for all of the participants. So just watch for that, click through really quickly, and then obviously you can see everybody's faces again. Thank you.
Okay, so who'd like to go first? Who's coming off of?
I'll jump in. This is Sarah. I know it's hard to see all these Brady Bunch boxes and which one of the talking heads is talking. So I'll offer two things just by way of reflecting on what both Mickey said and what you're teeing this up for us, Alex. The first is that I think the value proposition is relative, right? Paul Keckley is a leading healthcare consultant. He talks about the relative value proposition. And so whether you're a clinician or a policymaker or a payer or a patient, what you value in this realm of data interoperability is going to be very different, right? Why you care and what you have to invest to commit to data interoperability is going to be different. So I think, what we're doing in these interviews is talking with all these different stakeholders. I know Cambia calls it the 5 points of value, and to just hear these different perspectives on why this work is important, I think is going to be really illuminating for the larger healthcare ecosystem. And it relates to, I guess, my second observation. Mickey was talking about how use cases really have to solve a real problem. It's not enough for it to just be theoretical or conceptual. And in some other work that I've done, we brought together patients, researchers, and health system stakeholders. And the health systems were and this was around data sharing, which is a close cousin of data interoperability, nobody wanted to be the first ones to share their data. And so what we did as a result of hearing this was go out and find 12 use cases that are doing data sharing, find the vanguard organizations and share and showcase what they're doing, not just what they're doing, but how they're doing it, so it can be of benefit to others. And so as we are talking to the vanguard organizations here for these use cases, I think it's going to be a great way to kind of pave the way and set up a roadmap for others to learn from and figure out what they really need to do to achieve these interoperability goals. So those are my 2 thoughts today.
Yeah, going off of what Sarah said, it really came clear of like, has to have a business case, have to repeat it over and over. Because something that has also come up during our interviews is that having that clinical outcomes case is really important, but without that business case tie, it's much harder to get something done because of the huge implementation load to get a lot of these fire cases. Since you're putting real money and real resources, if there isn't some clear financial improvement, it's often a much harder sell. What with the part of why I was asking about value-based care is with the value-based care approach, there seems to be more of a financial push for that. And so then it's a little bit easier to do that same value case because now